look, I'm getting these really funny heartbeats. Oh, that's anxiety.
Other aspects of lifestyle which may be relevant.
Be patient with yourself and just build up gradually.
So I just needed to have them work with me.
There's a whole bunch of cardiomyopathies.
Benefits of doing genetic testing.
Take their own heart monitor. There's better types of fat.
Try and find a cure for inherited heart muscle diseases.
So Jayne, if I may, to introduce the session is, what would be your top 3 tips for someone who's been newly diagnosed with cardiomyopathy?
Yeah, so if possible, try not to Google information. If you're going to look for information, and I think lots of people already will have Googled, try and look for information from UK-based reputable websites, so NHS UK, the British Heart Foundation, and of course ourselves at Cardiomyopathy UK. We've got a wealth of accurate and up-to-date patient information for all types of cardiomyopathy. Call our specialist nurses, so we're available on our helpline. That's Monday to Friday, 8:30 till 4:30. If you've got any questions or you just want to talk, then give us a call. We're only too happy to talk to you. We don't have a finite amount of time, so certainly if you want to talk for 10 minutes, an hour, then we're here to listen to you. And we're here, as I say, during our opening hours. We've also got live chat, which is on the front of our website, and you can drop us an email and ask questions, ask information. And understanding more about your diagnosis or your loved one's diagnosis, again, is one of the first steps to living well with the condition. So visit our website at cardiomyopathy.org. There's some information there about what is cardiomyopathy, and that's a good place to start. Newly diagnosed, certainly there's information that I've got at the back of the room. There's some leaflets there with the AV guy, so it talks about what is cardiomyopathy. So again, that's a good place to look at information and consider the information. And if you've got any questions, then let us know. Or you can call our specialist nurses. So there are 3 specialist nurses. So you can see there that there's Emma, myself in the middle, and then Carol, and you'll see us all on stand 8. So please come and say hello if you've got any questions or want to talk. We have a dedicated room, you can come and have a chat with us. So call up our nurses on our helpline if you've got any questions or want to talk. And again, understanding more about your diagnosis is the first step.
And actually, Jayne, a question that I would have as well is, what can you, as a specialist nurse from Cardiomyopathy UK, offer a person who is newly diagnosed with a condition?
So we can offer information, we can talk through with a specialist nurse what is cardiomyopathy, medications, treatment options. Obviously, we can't give you clinical advice because we don't know what your ECG shows, we don't know what your echo shows, but we can give you general advice and information. Support, so we can have one-to-one time with you to listen as long as needed. And as I said, there's no time limit on the phone call. And certainly, you can do live chat on the platform on the front of the website, so that's good for little questions you've got. Or we can arrange one-to-one Zooms with you. So if you want to have a video call with us, then certainly, we can arrange that at a time and date to suit you, obviously, hopefully within our working hours. But, if we have a conversation with you, we can offer that at other times. Support, we've got online nurse-hosted groups, so those happen on a weekly basis. So we have what we call topic groups, so there might be a group for people diagnosed with dilated cardiomyopathy. It might be that week's group is people diagnosed with hypertrophic cardiomyopathy, and it's an opportunity to meet other people also diagnosed with the same condition. Within the topics, we also have a group about devices in cardiomyopathy, so you can come along to that group if you've had an ICD implanted, if you've been advised to have an ICD or a CRT. Come along, have a chat to other people, ask questions about your thoughts around your device and what you've been advised. So there's an opportunity to come along. We've got nurse webinars that we do, so we do those at least twice a year, and those are on our dedicated YouTube channel for you to come and listen to. You can't, yeah. Not as a HCP. No, we can't take direct referrals from HCPs. You'd have to get the patient or their loved one to ring up on their own behalf. Yeah.
So you don't have access to ECGs and echoes, but you give advice on medications, that just potential side effects?
Just, yeah, general. So if someone's on a beta blocker, they've got hot, cold hands and feet, then obviously we'll talk to them about that, yeah. But it is very general advice. We can't say switch to this or switch to that or take it in the evening or take it in the morning. We don't do that. We don't look at ECGs and we don't look at echoes either. But obviously if someone says, you know, this is what I've been told, then we can obviously talk around that subject. We offer one-to-one peer support, and that's obviously a regional thing, and there's regional support groups. So that's within stand 7, if you want to have a look at one-to-one peer support, if you want to talk to someone else newly diagnosed, and we can arrange that for you. And Christy Jones is our peer support coordinator, so he can certainly speak to you if you want to arrange to go to an in-person support group. We also offer advice on living with cardiomyopathy, so lifestyle, exercise is certainly a topical question we get asked quite a lot. We can only give general advice on exercise, but obviously we will give you advice. We can talk around genetic testing, what that might look like for you, and also around preparing for your cardiologist or cardiac nurse appointment. We're obviously happy to talk around that sort of questions you might want to ask. And receiving a new diagnosis can certainly be very daunting, it can be very scary, and many people will only hear a very small percentage of what is said. So they may, you know, call us and say, you know, I've been diagnosed, I've got an appointment, I don't know what to ask, I don't know what happens now. You may have heard complex terminology, akin to almost a secret language, ejection fraction or hypertrophy. What do those words mean? It can take time to certainly understand medical terminology, and understanding is a key to good communication and reasoning. And some people will Google words for medical reports, which will cause anxiety and fear, and others may even turn to social media platforms, upload their reports and asking lay people to provide opinion, and again, that can be very anxiety-inducing and worrying. And our nurse team are here for you. Our specialist knowledge means we can help you navigate through the journey of understanding. And certainly after Prof's talk and the Q&A that will probably follow, then we're here for you to talk to you. So let us know, give us a ring, you know, we're here to talk and listen. I've got some of our information resources for you here, which I'll leave at the back with the AV gentleman. Please feel free to come and take one at the end of this session. And last but not least, I need my clicker. We've got, at the moment, we're running a research question survey. So we've done a first survey as a research question as Cardiomyopathy UK. So, you know, we've shortlisted them down to some questions, and what we need, if possible, for you to say, you know, these are the research questions we would like to be considered for asking at the end. So certainly go and see, you know, our guys at the research stand and let them know that you might be interested. Scan the QR code, and then you can complete the latest survey. So thank you all very much, and I'll hand over to Prof.
So, good morning, everyone. Good morning, everyone. Good morning. Much better. Jayne? So, welcome to the meeting. Now, guys at the back, can I move from here, or does that really annoy you? It really annoys you. Okay, right. Okay, so this is the first of several talks I've got to give today. Let's get rid of this. First of all, how are you finding the conference so far? Excellent. Numbers look as though they're up from last year. Okay. Now this one, I have to admit, when I saw this title, I wasn't quite sure how to pitch this one. So what I'm going to give you is almost like a cardiologist view of what new diagnosis looks like. But what I really want to do is to get as quickly as we possibly can to the Q&A, because I think that's often the more useful part of the presentation. Now, in terms of what it looks like, here's an example of someone who gets a new diagnosis. So, middle-aged man. He presents with atrial fibrillation, which is this very common rhythm where the top chambers of the heart no longer beat in time with the bottom. They do their own thing, become very rapid, very common. He's treated with what's called cardioversion, so he's put back into a normal rhythm. He has some additional investigations. His left ventricle, the main pumping chamber of the heart, is not beating as well as it should. So he's put on a drug that we often use in that situation, Ramipril. 4 years later, he goes back into atrial fibrillation. This time, he sees an electrophysiologist, cardiologist who likes setting fire to the heart to burn out rhythms, and they get him back into a normal rhythm again, but once more, it's noted that his left ventricle is a bit below par. Jayne mentioned this concept, the ejection fraction, which causes enormous confusion, but it's very simply the difference between that and that as the heart beats. And normally the heart beats 55% of its contents with each heartbeat, so certainly anything less than 50% would be seen as abnormal. So this time his treatment is optimized a little more. He's put on a beta blocker. Because of the recurrent atrial fibrillation, one of the risks of that is developing clots inside the heart. So he's put onto a drug to thin the blood, and he's scheduled for a further ablation. Has an electrocardiogram, and someone actually looks at it, and they say, oh, this is a bit abnormal. And electrocardiograms are all about pattern recognition. And this guy's ECG is abnormal, and yeah, it could be explained by a prior heart attack. He has an angiogram, but his vessels are lovely and clear. He has an echocardiogram, which again shows this is the main pumping chamber of the heart, the left ventricle. This is one of the top chambers, atrium, mitral valve, and the overall squeezing function is, I say, around 45%. That story is not particularly unusual in cardiology practice. But what happens to you and the kind of advice you get does depend on which pathway you're pushed down. Cardiology is like the rest of the world. You know, we all think we see the world in the same way, but we really don't. So one way of thinking about what this guy has is what I might call the heart failure paradigm. So in the heart failure world, which is a big world, a lot of people with heart failure for various causes, it's often classified according to the severity of dysfunction of the heart. So we talk about HFrEF, which is heart failure with reduced ejection fraction. We talk about HFpEF, which is heart failure with preserved ejection fraction. And then we've got one in the middle, which is HFmrEF, which is heart failure with mid-range ejection fraction. And it's not entirely arbitrary, this, because this is the basis of clinical trials and the drugs that we use, the ACE inhibitors that some of you may be taking, beta blockers, a drug called spironolactone. These are all based on this classification of disease according to how well the heart pumps. Alternatively, you might see a cardiomyopathy kind of person, and they'll say, oh, this is very interesting. You've got probably a dilated cardiomyopathy. We're going to put this into a different box. And then the conversations go down two different pathways. If you're in the heart failure pathway, focus on the ejection fraction. We're going to put you on some good drugs. Yes, this means cause etiology. We're going to determine the cause, but that basically means measure the blood pressure, make sure the coronaries are okay. Or in cardiomyopathy land, we say, oh, that's very interesting. You've got a cardiomyopathy. There are many things that could cause this. I have to say, these kind of lists are not very helpful. You know, you can come to my arsenic poisoning clinic on a Monday morning. Yeah, I mean, yeah, not very helpful, really. But in the world of dilated cardiomyopathy, which is where this guy might fit, we often talk about genetics. We may talk about viral infection. We may talk about immune disease. If any of you have got dilated cardiomyopathy in the audience, you'll know that there's a huge emphasis on the genetics of this. The reason for that is if you look at families, about 25% of individuals will have at least one other family member who's affected. So there's a strong genetic component to this type of cardiomyopathy. And there are lots of genes, 80, 100 different genes, which might cause the condition. But that conversation doesn't generally take place in a standard heart failure clinic. So depending which track you go down, the conversations will be different. You're going to be hearing a lot about this document, which has recently been published. This is the latest European Society of Cardiology guidelines for all cardiomyopathies, which is a first. So this is a new guideline. We did have a guideline on hypertrophic cardiomyopathy. This is the first guideline which tries to encompass this enormous family of conditions that we call cardiomyopathy. And what this tries to do, it's trying to bring together these two worlds, with the focus just on the function of the heart, with the focus on cause. This, if you like, is the sort of thought process that is trying to be encouraged. So first of all, how you approach someone depends on the scenario. So if you've already got a family history of the disease and you come along for evaluation, the emphasis is going to be very much on a genetic cause of disease. Conversely, if you're a young, fit athlete and you're training for the Olympics and your ventricle's a little big, but the function's okay, then that could just simply represent athletic adaptation. So the context, the scenario is really important. The next thing is that you describe what you see. So we take echoes, MRIs, whatever it is, and we say, is the heart thick? Is the ventricle dilated? Is there scar in the ventricle? And then, if you want to, you can put it into one of the boxes, which many of you will be in. You'll be in a hypertrophic cardiomyopathy box or a dilated cardiomyopathy box. But we don't want to stop there. We want to start thinking about, are there other things going on which might tell us about the cause and how to manage this? So are there problems with the electrics of the heart? Is there a family history? Should we be thinking about genetic testing? And at the end of this whole process, yes, you've got HCM, you've got DCM, but we're moving towards the answering the question, why? Why do you have it? To show you how this sort of pans out, if you take what I would say is the traditional heart failure way of thinking, so the man we've got, if we put, he's got atrial fibrillation, he's middle-aged, he's got mildly impaired LV function, we've looked at the degree of that, and then depending on how badly the ventricle is affected, we might put him on beta blockers, ACE inhibitors, dapagliflozin, one of 4 classes of drug. And that's all fine, but it's not very granular, it's not very informative. This guy, we need to think about his family, we need to think maybe about genetic testing, there may be some other markers that we need to think about. And this guy, when we did an MRI, this is a cross-section through the heart, the donut shape is the left side, this is the right side wrapping itself around the left. There's a scar here, which you couldn't see on the echocardiogram. And this particular pattern, again, pattern recognition, suggests some particular gene mutations. We've assessed his heart rhythm. He's getting a few extra beats. And then when we actually sit down and bother taking a family history, his father died from dilated cardiomyopathy, age 50. He's got a sister who's also got left ventricular enlargement, and we do a genetic test, and that's just code for a gene called desmoplakin. So this enriched way of looking at his disease is that, yes, he's a middle-aged man with atrial fibrillation, with mildly impaired function, but he's got extra beats, he's got this variant, he's got scar. We can put him into a different box, but the important thing is if you take all that stuff, that's going to determine how we manage this guy. And it's this actionability. So this is me sharing you. I've sort of reached one of those landmark ages now, and I'm looking back at what I've been doing for the past few decades, trying to persuade the world of cardiology to listen. For God's sake, listen to me. But not unreasonably, the response has been, yeah, we're listening, but you're not telling us to do anything differently. Tell us when it makes a difference. The actionability of knowing a gene variant, knowing that there's a family history. Well, it does make a difference. For many of the conditions, we're going to treat it, if we call it heart failure with reduced ejection fraction or dilated cardiomyopathy, the core medication will be the same. But we're also going to start thinking about family screening this guy, because it gives us an opportunity for prevention of disease, or at least prevention of complications in relatives who may be affected. And what are those complications? Well, in many of these conditions, people are prone to life-threatening arrhythmias. So if we can identify people earlier and stratify them appropriately, we can protect them in the form of a defibrillator. And for some genetic forms of the disease, lifestyle is critical. Lifestyle actually may be, if you have particular genetic mutations and you follow intense physical exertion, you may make the condition worse. So in dilated cardiomyopathy, we give all the usual drugs. Within the new guidelines, we've got this extra bit now where we say, okay, you look at the function, but then think about genetic testing. Because once we know the gene, for some of these subtypes, we've got these risk scores which allow us to say, okay, well, over the next 5 years, we estimate your risk to be 1% or 5% or 10%. Now let's have a conversation about whether you, we, all together, we think you should have a defibrillator. So that is sort of ivory tower cardiomyopathy land, but it is the standard that we're trying to promote through the new guidelines. But as Jayne said, there's a whole other dimension which also needs to be tackled in this sort of cardiomyopathy mindset. Because we can sit there, we can go through the risk tools, we can say you should have a defibrillator, but how do you negotiate this pathway from diagnosis, confusion, feeling very isolated, having the Google moment, to then starting to understand the potential implications of this for your employment, for your family. And that's where sort of the broader spectrum of management, of advice, of support comes in. And that is often not, and it's probably best not done in my clinic on a Monday morning. It's part of that penumbra of support that people need, at least for a period following diagnosis. Not necessarily, in fact, ideally not for the rest of their lives, but just to get you on over that hump of diagnosis to allow you to manage the disease yourself. I think you can access this. I don't think you have to pay €400 and become a member of the European Society of Cardiology, but the guidelines are here. They are, I think, obviously they're written in a very medical language, but they are meant to be patient-centric. And they do try to set the bar quite high with regard to how we think we should be managing people with cardiomyopathy. But I think so far the reception of these guidelines has been very positive. And I think we have reached that tipping point where people will now say, reduced ejection fraction, this is like to be a cardiomyopathy. Why? And where does that take us? So I'm going to stop there. And now I'm going to open it to you. Yeah. So this is, again, I said I'd reached an age where I'm looking back. And I can remember my very first year as a research fellow, where I gave an interview, which was fortunately lost in the midst of time, to Scottish television. And I expressed the view that the evidence to support screening with ECGs on a population level wasn't there. I can tell you that's given me more than 30 years worth of grief. But I still, my position is still the same. I mean, the question comes from a desire to stop young people dying suddenly, right? Or anybody dying suddenly, unnecessarily. But does screening everybody with an ECG prevent that? And my argument is that the evidence suggests that it doesn't. The best experiment for this is Italy, where actually you don't have to be a sports person. If you're a kid and you want to participate in sport, you've got to have an ECG. And there's one paper from 1,000 years ago which suggested it reduced the rate of sudden deaths. Only for one condition, hypertrophic cardiomyopathy. The difference was 4 deaths over about 30 years. And it had no impact on the things which actually kill young athletes, which are inflammation in the heart, other forms of cardiomyopathy like ARVC. I often use the example of the young footballer who has a cardiac arrest on the pitch. Plays for first division team. Remember, these people have been screened multiple times. Multiple times. It surprises me that people don't see this as a failure of screening. For me, the emphasis should be different. The emphasis should be on the survivability of an event. And that's certainly the approach that's been taken by some other countries, for example, in the Netherlands, where it should be about having a population that can resuscitate. In Norway, you don't get a driving license unless you've had a CPR training. In many European countries, the kids have to have training in CPR. And in some schools, it's like that here now. In Sweden's an enormous country with lots of snow and mountains. So if you have a cardiac arrest at the top of the mountain, there ain't going to be a defibrillator in a box down the bottom of the lane. So what do? You send out a defibrillator on a drone. So survivability is the key thing. And rather than pretending, because I know it's a bit harsh, but I think pretending that we're going to prevent sudden deaths by doing a test in an adolescent. And of course, these conditions develop throughout life. So the logic is that you should not just do one, but you should maybe do it on a yearly basis, 2 yearly basis. Yeah. So a long answer, but I hope that explains why I gave that interview 30 years ago. I think the overall level of care that people get for cardiomyopathy, when I look back over 30 years, is completely different. It's much, much better. Much, much better. But we still encounter these sort of formulaic approaches to people. And it's not just about knowledge. In fact, the least of it is knowledge. It's actually much more about how you interact with people. It's about the humanity of healthcare, which unfortunately doesn't always work very well, for a whole variety of reasons that we can debate over. Yeah, probably a glass of gin if we can find some gin. But it's about how you relate to people. And that's maybe what we're doing wrong now in the way in which we train healthcare professionals, I think. It's the questions, and it's also, so again, when I started this 30 years ago, my boss at the time made his research fellows come to this kind of meeting. Because if you're a doctor or a nurse, you're very exposed in front of you guys. Because in a hospital setting, we've got lots of defenses. You know, you're at a disadvantage. You know, you've been waiting outside for 3 hours. You're coming into this little room where he's got computers and nurses. You know, we're in charge in that situation. But in this situation, we're not. But what did I learn? You just talk to people like they're people. You know, it's one of the things that we as healthcare professionals often feel is that we've always got to have the answer. It's not always having the answer, but it's fessing up when you don't. Well, let's ask people, do you expect your healthcare practitioners to have the answer to every question? So, yeah, why not? Why not?
You don't know all the answers, so how do you expect?
Yeah. For me, I mean, again, I don't want to sort of misinterpret, but my experience has always been that what people don't want is BS. Yeah, don't tell me that you know something when it's bloody obvious you don't. So that, I think a lot of what we do in a clinic is about managing uncertainty. Because we don't have all the answers. We have more than we used to, but a lot of this is about managing uncertainty and helping you to manage that. And you know, often there's a more right decision than a bad decision, but a lot of the time it's equivocal. And it's the right decision for you at that moment in time in your life. But that's not a textbook answer, yes or no. So, again, another advance in the guide, well, it's now what we call a class 1 indication, which means must do, unless there's a good reason not to. So if you have a diagnosis of cardiomyopathy, then we're recommending that everybody should be offered genetic testing. Doesn't mean everybody will have it or will want to have it, but it should be offered. Now that recognizes the fact that all cardiomyopathy subtypes can and often are genetic. And it's also built on the emerging knowledge that we have, which shows understanding of the genetic basis of disease may help manage the individual, but of course has fundamental implications for a family. So the criteria, in a way, have been simplified. You know, if you fulfill criteria for a cardiomyopathy subtype, then you should be offered genetic testing, which I realize is not always possible, although in the UK setting, theoretically is. Things like ChatGPT and so on, this is basically, it doesn't have a brain. It's an incredible tool for sucking out information from across an enormous resource. We were talking about the internet and so on. And it is not possible for anyone to go around with this huge volume of data and information in their heads anymore. The gentleman asked me about genetic testing and cardiomyopathy. So I don't know, there's at least 2,000 variants in hypertrophic cardiomyopathy which cause disease. Similarly for the other, I don't carry that around in my head, nobody does. So I think AI has enormous potential as a tool to allow us to manage data and to integrate that data with other data sources which allow us to model outcomes better and that sort of thing. I think AI is really getting traction for image interpretation. And it's always phrased that it's as good as top experts, which means it's better than a lot of other people. But if you want to scan high volume, MRI, echo, and so on, then AI again I think has a great role. Genetics as well. So I think it's here. It's a reality, and we have to adapt our healthcare to that. Now I still have a stethoscope. I still touch people, I touch patients, I still talk to patients. And I'm starting to feel a bit like a dinosaur by doing that. But what I think we need to do is to change the way in which we train healthcare professionals, not to memorize textbooks, but to actually understand and develop methodologies, techniques, which mean talking to people, listening to people. I think the danger is that we're going to become passive recipients of information from a computer. And that honestly does worry me because I see it already happening. Where someone is looking at a screen and say, your cholesterol is this, you need to take these tablets, and they haven't even looked at the person sitting next to them. So AI, I think, is a great advance. It is here to stay, but we've got to try and somehow reintegrate the humanity bit and the common sense bit with AI.
But I don't know whether you can advise on this today or whether there's somewhere that I can go to read about the TTN variant specifically and, what kind of exercise I perhaps should or shouldn't be doing. And again, if I was to consider pregnancy, is that advised with that specific variant?
Okay. So these are all really important questions. I'm going to duck it slightly because this is at least half an hour's discussion, but it's a great illustration from what I was saying about the value of genetic testing. So what you have is a variant in the commonest gene affected in dilated cardiomyopathy, maybe 20%, something like that, 25%. You're right in that for some people the disease seems to be triggered by pregnancy or chemotherapy, or probably not so much lifestyle like exercise, that sort of thing. But as always in cardiomyopathy, it depends, because variants in that gene are also quite common in the general population. So 3 in 100 people in the general population also carry significant variants in that gene. So what we're collectively trying to do is to understand who is it that's going to go on to develop problems. And that's emerging evidence. So this is a long discussion, or should be a long discussion, but you're right, it's identifying the potential risk factors. Do you mean to modify life? What can you expect? What is the likely response to therapy should there be a problem? Because it does seem to actually be very responsive to therapy. But it's a very, very focused gene-specific piece of advice, which is why we think everybody should have genetic testing.
One was about the conversations that health professionals have with patients. I think it's really hard because health professionals are taught to give support and reassurance, and so when somebody comes to them, they want to give positive messages. And one of the best ways that I've heard a health professional respond is by saying, I don't know all the answers, but here we're going to try and rule out some of the terrible things that we know. Yeah. So it's the ruling out, and that I think can give some reassurance. And then on death, dying and loss conversations, which is what you were referring to in terms of DNAR, I think as a population we're terrible about talking about death. So when our health professionals talk about death, they are not trained in their medical schools or in their nursing schools to talk about death. And the only way we can change that is by getting a population approach and talking about death. We are born, we live, and we die. It's not a taboo.
Yeah, no, I couldn't agree with you more.
So I think that's
the sad thing is it
changing.
is taught in medical schools. It's taught.
Well, yeah. I don't think not that much.
And doing a half an hour lesson on a wet afternoon, that's not how you teach people how to do it.
No, it's conversation. It's like you're saying, talking to your patients.
I don't know if I'm good or bad at it, but I did it by watching others and being there and being part of that experience, which again is something that I think we've lost a bit with training, because we're Well, don't start me on that one. But,
No, but it's interesting. I mean, both of those things are very valid points,
yeah.
but something that we all need to talk about.
Yeah.
It's okay to die. Just do everything now.
Yeah.
We all will. Yeah.
Hi, my husband's got HEM and he has chest pains for the majority of his daily life, and he tolerates that really well. And I'm just wondering, when does he just have to tolerate and ignore it, and when should he actually do something about it? Because sometimes his experience has been quite negative. He might go in and then just be sent home, and he always feels quite reticent to go now, even when it's quite severe. Yeah. So just would like your opinion on that, please.
So it's, I think what's the next talk I'm doing? I think it's personalised medicine. And personalised medicine, there's a lot of fancy stuff about new therapies, but actually personalised medicine is also about understanding what an individual's symptoms are. And there are some significant unmet needs in the kind of symptoms that people have to live with. And one of those is chest pain. Even the word can be confusing. So, communication. So in the clinic, I always ask the question 2 ways. Do you ever get chest pains? No, doc. Do you ever get tightness in your chest if you go up the stairs? Yeah, of course I do. Because that's an ache, that's not a pain. So being able to understand what the symptom really is, if we can, trying to understand the mechanism of the symptom. So in hypertrophic cardiomyopathy, reproducible exertional symptoms, whether it be pain or breathlessness, may be caused by this phenomenon of obstruction, which we'll talk about in other sessions today. And if there is obstruction, there are actually quite a lot of things that can be done about that. And it may be there all the time, but it may only be there if you do a particular test, if you stress the person on using an echo at the same time. A few people will have chest pain which isn't related to obstruction, and then there are some drugs that we can try. So there's a drug, anybody on ranolazine? No, hardly anybody. So, yeah, you're on ranolazine? Okay. Did it help? No, it's often all or nothing. It either does or it doesn't. There's no halfway house. So there are some drugs that could be tried. But I suppose the answer is that the symptom needs to be understood, if possible, the mechanism identified, and then sometimes there's something we can do. Not all the time. And so that's why we still need new therapies. Does that make sense?
Thank you.
Yeah.
Thank you.
But the other issue too is that when you recognise it as being coronary artery disease,
Well, you have to exclude it, sure. Yeah, you have to. Sure. I mean, most people, your experience, a lot of people, the experience they have is that they go to A&E repeatedly with chest pain, and everybody says, you haven't had a heart attack, go home. Or they've had 4 angiograms and the arteries are still normal. So there are certain stereotypic experiences that people have. Yeah.
My son was diagnosed with non-obstructive hypertrophic cardiomyopathy, and was asked to, as his father died in his 50s in his sleep, to try and get a copy of his death certificate. And my son had lost touch with his stepmother. Anyway, my husband and I worked on getting hold of this post-mortem certificate, which was complicated and hard because he died in 2001. Eventually, we got hold of the post-mortem certificate, which should be with your secretary now. As he's
where is this going?
But we only managed to get it because he died in a census year. It had been kept. Everything else after, I don't know if it's 12 or 15 years, the post-mortem gets destroyed. I think that's very negative for young people trying to find out the history of, this father had a sudden death in his sleep in bed, and about 54 years of age. It's important people can get the post-mortem report, but that was only just luck that it was a census year. I think it's awful that the rest are destroyed.
It is awful, and again, we could talk all day about this element as well. A commonly misunderstood thing about when someone dies, they have a coronial post-mortem, etc. The coroner is not a medic. The coronial system is a legal system. And the overwhelming majority of coroners are lawyers doing it part-time. Their sole responsibility is to say whether this was a natural death, i.e. not poisoned, not stabbed, not shot. It's not to say what the cause of death was.
No, well, he did have a post-mortem.
Oh, no, sure, yeah. But that information sits within that legal system. It's not part of the healthcare system. And that record is not sort of seen as part of your health record or the health record of that individual.
As it happens, it did say, the post-mortem from the doctor did say about cardiomyopathy, which was interesting because he hadn't been to the doctors previously and had it diagnosed.
So I've got him campaigning not against the heart, working with the British Heart Foundation to correct the information. One of the things we've struggled with for forever is updating our 900-year-old coronial system. And I have some sympathy. I think there are 180 coroners for England, and they have to process 100,000 postmortems a year. They have about 200 quid, I think, to spend for each postmortem. So it's boom, 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 But the record keeping is medieval, the way in which it's done. You imagine there are people writing on vellum the report, but it's some coroners' offices don't even have computers. So it's one of those sort of dark areas of our public life which really needs a light shone upon it because it's not fit for purpose.
Thank you.
Good practice, sharing frameworks, etc.
I think in terms of things like national guidelines or international guidelines, I think most medics, it's to read the document from front to back, no, because there's a ton of that stuff. But being aware it's there, some of the headlines being flagged up is happening all the time, and particularly, no offence to any of my medical colleagues who might be in the audience, but you see a different way of handling information amongst younger cardiologists. They're on the phone all the time. They're getting information all the time. They're getting updates all the time. And it was a bit like the question I gave about AI. You don't need to memorize the whole document, but just being in touch with what's happening, I think that's probably better than it's ever been. Where I thought you were going to go with your question was about sharing information between different healthcare settings, from general practice to hospitals, between hospitals, and that is, but it should, here we are talking about AI, and I've got no automated way of seeing an echo that was done in another hospital. You have to formally request it. So that's when, if I appear cynical about AI, it's because that's my daily reality. Not generally, no. So do you have a genetic mutation? Or have you had genetic testing? Or?
Yeah, but they don't know.
So I haven't found anything, So the general advice would be, is if your daughter is okay, that you wouldn't then start a process of screening in the long term for her kids. If you really push me into a corner and say, is it possible that she's carrying something, not showing any evidence for it, pass it on? It's possible, but it's extremely unlikely.
Yeah, and would it be like an echo looking for an enlarged heart or something?
Well, fortunately, non-compaction is a slightly controversial thing, but it's something that you would be born with.
Yeah.
So if it's not there, it's not there. So it's not going to develop.
But then you're born with it, but mine didn't show till I'm 60. So if I had a
So you might have developed symptoms later. I don't know how you were originally diagnosed, but in terms of all those extra muscle bands and stuff, they're there from.
If I'd have had an echo all those years, it may not show.
Or it may have been picked up earlier. Yeah. So what we're talking about here is that in the new guideline, there's this new term that's been proposed, which is non-dilated left ventricular cardiomyopathy. That was 2 years' worth of debate because it's a bit clunky. Distinguishing it from hypertrophic, dilated, arrhythmogenic right ventricular cardiomyopathy and restrictive. So quite a lot of people are now coming along and say, hang on a minute, I've been told I have arrhythmogenic cardiomyopathy. Where do I sit here? Do I not have it anymore? And this is quite controversial. So before this term, there was this catch-all term that had been developed called arrhythmogenic cardiomyopathy, which was a big bag of stuff which sometimes affected the right ventricle, sometimes affected the left ventricle, sometimes affected both. There was no definition for it. In a way, all cardiomyopathies can be arrhythmogenic. And it was an attempt to try and rationalize the appearance of this disease, which is a disease which isn't dilated. You've got scar. It may or may not be arrhythmogenic, and was being lost. So what we decided was to get rid of the term arrhythmogenic altogether and just to start by describing what we see, but then really push this concept of asking the question, why? Because in a way, the initial label, of course, is important, but it's more important to understand why you have a big heart, a scarred heart, a lot of arrhythmia. So there are, if you think through this particular way of doing things, there are going to be certain circumstances where it's going to be a bit fuzzy what label you put on it. What do you do if someone's got predominantly a right ventricular problem, but there's a little bit of disease on the left? But for me, that's what I call cardiomyopathy bar talk. It's for sort of specialists to have a fight in the bar in the evening, say, oh, I think it should be over. Actually, the key thing is, whatever it is, what's causing it, and what does it mean for me in terms of treatment, my family, and all the rest of it. But so I'm glad you asked the question. I've given a really confusing answer. But this was a very deliberate attempt to raise the profile of an entity that was not being picked up in routine practice.
So is as someone who has just been diagnosed with
Yeah.
is the onus on me to go back to my therapist and have a conversation, or will they come to me and be like...
No, they're not going to come to you. I can tell you that now. So I think you go along in a non-threatening way and say, this is really interesting. The ESC Guideline says, where do I fit on this spectrum now? Have you had an MRI?
Yes.
Okay, good. So, yeah, just get in the driving seat. So as a cardiologist, I can make my life very easy. You have hypertrophic cardiomyopathy, don't do anything. But I've got to travel, I've got to carry a suitcase, I may have children. I mean, what does that mean? I just have to sit doing nothing. And of course, nothing bad is going to happen if you carry your suitcase, or if you play with the kids, or you go and visit Nonna in wherever you come from. It's not so, but it has to be individualized to some degree. In general, for most cardiomyopathies, activities of daily living are all fine. You've got to go upstairs, you've got to do stuff, you've got to get out there, and that's a much more healthy way of managing your disease than sitting there desperately frightened to move. Nothing bad's going to happen if you do those kind of activities. The advice needs to be tailored a little bit to the nature of your condition. Is it obstructive, non-obstructive? Non-obstructive, okay. So, if someone has obstruction, there may be particular kinds of things you avoid. Trying to optimize your medication to minimize your symptoms. So there's an individual discussion that needs to take place. But the kind of things you were describing, life is full of cliches, and one of the cliches is listen to what he's telling you. So if you're doing something which causes you distress, then you've probably crossed the line for you. If you can do it without as long as you're not sort of proposing to go and run in a marathon, if you can do it without discomfort, it's probably okay. So palpitations are a bit like chest pain. It's one of those very important symptoms. It usually means you've got an irregularity in your heartbeat. It's likely to be that rhythm I spoke about earlier, atrial fibrillation. So if she's still getting it despite treatment with the beta blocker, then she needs to sort of go back to the cardiologist. It needs to be documented. Does she need an alternative drug? Should she be on a blood thinner? It's entirely manageable, but she needs to let her specialist know.
Sorry. The symptoms that you might be new are dangerous as opposed to just okay. Does that make sense?
Yeah, it completely makes sense. It's a little bit like what you were saying about chest pain. When should you shout about a symptom?
Yes. Should I trot down to A&E? I don't think that's Yeah.
So it depends, but if it's a new symptom, if you get any new symptom like palpitation, like chest pain, like a blackout, then I would always seek medical advice. So if it's something which hasn't happened before, if it's something which you've sort of had before, but this is a really bad one,
Yes,
then I would seek medical advice.
Okay, right.
So that's what I mean. It depends slightly on the gravity of the symptom.
It's got worse.
Yeah, so I would then seek advice.
Okay, thank you.
Yeah, so yeah, you're taking me down a political pathway now. So, but it's a but it's a political pathway for us all actually, because that's rubbish, but that's normal. That's the healthcare system we have. Yeah, I think we've had a discussion about this, haven't we? And so I think we collectively have to decide what we want from our healthcare system. It is, in my mind, someone's just, you've got hypertrophic cardiomyopathy, whatever it is, you have your Google moment, I could die, I've got pain, of course you're bloody anxious. 6 months of agony, waiting for something to happen, that's not acceptable, but is that unusual? It's not unusual, and not just in cardiomyopathy, it doesn't matter whether you've got coronary disease or potential cancer or whatever. That is not the way to treat people. But it's an inevitable consequence of the kind of healthcare system that we have.
So what's the answer?
I'll give you one thought to go away and muse over. We have two thoughts. We have to, and we're getting away from this, but the NHS needs to stop being a religious icon. Well, no, but the politics follow on from that. So, certainly as a generational thing, you cannot criticise the NHS. The NHS is the greatest healthcare system in the world. It is not.
It used to be.
I'm not sure it ever did. Maybe right at the beginning. It was at the beginning. It was unique. 1948. So it gave people a lot of false teeth and glasses. Yeah. So there's that bit, but the second bit is we're living a lie. Brothers, follow me into let me finish the lie. Because the lie is that you can have a world-class healthcare system which provides everything on low taxation. And it cannot be done. It cannot be done. And as crazy as it seems, I actually have quite a lot of sympathy for politicians on this. Because remember, politicians, I don't have any relatives who are politicians, okay? But politicians are a reflection of us, good and the bad. And politicians are in a very difficult position because if any politician steps out of line and says, do you know what, maybe we should go to a mixed system where we have compulsory insurance, how long do you think that person's going to be there? As a minister, 5 minutes. But if you look at every other Western democracy that runs perfectly good healthcare with results that are better to us, with mixed system, there are not people lying on the streets dying, begging for healthcare. So it's a really long answer to your question. I'm sorry to turn it into this kind of answer, but your experience is not acceptable, but it's something we all experience every day in the healthcare system.